co-director of the Pediatric and Adult Congenital Heart Center at Cleveland Clinic. Dr. Marino is an internationally recognized pediatric cardiovascular outcomes researcher. His research interests have focused on the impact of surgical and intensive care unit factors on mortality and morbidity, as well as the impact of neurodevelopmental and psychosocial and physical morbidities on the quality of life, functional status, and behavioral and emotional outcomes in high-risk complex congenital heart disease populations. He's also pursuing novel investigations on the impact of neurodevelopmental health on cardiovascular health in the young. So welcome, Dr. Marino.
Thanks, Cheryl. It's a pleasure to be with all of you today. Thank you so much. Can everyone see my slides?
Yes, looks good.
Great.
Thank you.
Again, I want to thank Joelle for allowing me to chat with you today on neurodevelopmental and care coordination needs of children with congenital heart disease. This has been a passion of mine for more than 2 decades now, and I'm really excited that all of you are interested in learning more about how we care coordinate for patients, not just with congenital heart disease, but other chronic lesions in the pediatric space. My disclosures, I've got NIH grant support. I'm the creator of the Pediatric Cardiac Quality of Life Inventory that you'll hear about. I do have several national leadership roles. This is just an important slide that you see that across the country overall in the STS database, only 3.2% of the children that have congenital heart surgery today will actually die from during their first 30 days after their operation. At a place like Cleveland Clinic, ours is 0.65%. Most of the high volume centers have lower rates of mortality, less than 1%. It's important as we think about these patients to think about what are the areas as they grow up and they develop long term that they may have issues. So it's neurodevelopmental, neurocognitive, psychosocial, and psychiatric, late surgical or catheter-based reinterventions, arrhythmias, chronic heart failure, transplantation, pulmonary hypertension, endocarditis, or other important end organ dysfunction, including renal, liver insufficiency, and coagulation leading to thromboembolic complications like stroke. Today, we're going to talk to you specifically about neurodevelopmental, neurocognitive, psychosocial, and psychiatric issues. So there's been, literally 2 decades now of research looking at the causes of neurodevelopmental and psychosocial disability in kids with congenital heart disease. It occurs in about half the children. We know that this is a genetic predisposition for congenital heart disease and for brain abnormalities in kids with congenital heart disease. But there's altered cerebral blood flow, there's environmental exposures, including the impact of the placenta. There's, as a result, delayed brain maturity with white matter injury at birth in 1/3 of the children. They have surgery, and another 1/3 of them have more white matter injury, and as a result, 2/3 of the kids that leave the hospital with congenital heart disease who've had surgery will have acquired white matter injury and/or abnormal microstructure and decreased connectivity in terms of how their white matter is organized. We know that's impacted by hypoxemia or lack of oxygen, additional surgeries. Developmental interventions may improve that. Drug exposures, a home environment, socioeconomic status obviously is a big impact, as the susceptibility genes both in utero, in the OR, and then after these children grow up and are in their environments at home. All these lead to ND disability. The neurodevelopmental phenotype in CHD survivors, again, in 50% of our survivors, shows a mild cognitive impairment with normal to slightly lower IQ and academic achievement, impaired pragmatic language, decreased visual construction and perception, poor executive functioning, higher instance of inattention, increased impulsivity with a higher instance of ADHD, and diminished fine and gross motor skills. These individual deficits and delays may be mild, but often occur across multiple domains. This high prevalence, low severity picture does not meet the classical criteria of a learning disability. As a result, many of these children have difficulties in school, but may not qualify for special services. The psychosocial phenotype is also well known. Our survivors with congenital heart disease have deficits in social cognition. There's a higher incidence of autism spectrum disorders, and there's an increased incidence of psychiatric disorders, specifically in anxiety, depression, and post-traumatic stress. So I think what's really important is that these developmental delays that we see change over time. There's a paper from one of my colleagues, Kathy Masato, from Children's Hospital Wisconsin, 2014. And exposure to risk and prevalence of delay change over time. Therefore, repeat evaluations are warranted. And as you'll see later with CNOC, we'll tell you what those repeated evaluations should be. My paradigm for my research really focused on how should we maximize long-term outcomes in kids with congenital heart disease, and health-related quality of life is the new vital sign, and we need to be thinking about quality of life. We know that the kids with heart disease have various disease complexity, they have medical, surgical, and catheter-based therapies. Very few of them now die. The majority have some morbidity in the neurodevelopmental realm, psychosocial realm, or physical realm, and all three of these affect quality of life. The definition of health-related quality of life is a child's ability to function in situational context and derive personal satisfaction from doing so. We know the brain impacts both physical health and physical functioning, social functioning, and psychological functioning. I created the first disease-specific pediatric cardiac quality of life inventory back in the 2000s. This is our paper from 2010, laying out the validation of this pediatric cardiac quality of life inventory. I'm going to summarize 2 decades of research in a few slides. We know that quality of life in CHD survivors is lower than heart-healthy children. We know that quality of life in CHD survivors worsens with increasing disease complexity. We know that increasing medical care is associated with lower quality of life in CHD survivors. And we know there's a wide variation in quality of life score within cardiac subgroups. So when we think about how do we improve quality of life in these patients, we need to think about nurturing resilience in the neurodevelopmental and psychosocial space. So we need neurobehavioral and psychotherapy in children and adolescents to minimize the impact of social cognition issues, psychiatric issues, autism spectrum, and affective disorders and ADHD. We need psychosocial support to have the child improve their self-perception. We need therapy in patients and parents to prevent and treat post-traumatic stress disorder, symptomatology prior to invasive procedures in the ICU and during follow-up. We need programs to reduce parental stress relative to raising a child with chronic disease. These are the initial neurodevelopmental guidelines from 2012 put out by the American Heart Association. I was very privileged to be the lead author for this group. We're now working on a revised set of guidelines. The paper is in review right now with circulation. We expect this paper to come out in 2023 or at the latest 2024. So this will be a 10-year update from these original guidelines in 2012. So the goals of neurodevelopmental assessment in pediatric heart disease and CHD survivors is basically about surveillance, screening, evaluation, and management. We want to put interventions in place to prevent or treat the neurodevelopmental and psychosocial phenotype noted in the pediatric cardiac population to maximize long-term outcome relative to health-related quality of life, educational attainment. We want to reduce the incidence of anxiety, depression, and stress in family members and family dysfunction. We want to maximize adult transition and ACHD outcome. This is our algorithm from 2012. Bottom line is, this is the original developmental pediatric 2006 guideline. What we said here was, if a patient fits our high-risk criteria, which we'll talk about in a second, they immediately move right into referral for early intervention and making referral for formal developmental medical evaluation. I can tell you in the new guidelines, this has not changed. We've just refined the high-risk group. If you're in the high-risk group, you get evaluated and then you get followed on an intermittent basis, which we'll talk about in a second. So who is high risk? Neonates or infants who require open heart surgery in the first year of life. Children with other cyanotic heart lesions not requiring open heart surgery in the neonatal or infant period in the first year of life. Children with any combination of congenital heart disease and other comorbidities, which I'll show you in a second, and then other conditions determined at the discretion of the medical home providers. Here are the comorbidities that if you have CHD, we think put you in the high-risk group. If you're premature, your developmental delay recognized in infancy, if it's a suspected genetic abnormality and or syndrome, there's a history of mechanical support with either ECMO or ventricular assist device, heart transplantation, CPR at any point, prolonged hospitalization greater than 2 weeks, perioperative seizures, and then significant abnormalities on neuroimaging and or microcephaly. So the crux of these recommendations is that you need to have referral for formal developmental medical evaluation if you're high risk. You need referral to early intervention services or early childhood special ed services prior to confirmation of a specific developmental diagnosis. You do periodic reevaluation at 12 to 24 months, 3 to 5 years before the child goes to school for elementary school, and then 11 to 12 during middle school before high school, and then referral of young adults for higher education and vocational counseling. I'll tell you a little bit about CNOC, Cardiac Neurodevelopmental Outcome Collaborative. This is a brainchild of myself and several other national leaders. CNOC was created in 2015 officially as a 501c3 not-for-profit. CNOC is meant to be the multi-center, multinational, multidisciplinary group of healthcare professionals committed to working together and partnering with families to optimize neurodevelopmental outcomes for individuals with pediatric congenital heart disease through clinical, quality, and research initiatives, intending to maximize quality of life across the lifespan. There are 3 countries, 46 participating institutions, more than 1,000 members currently. CNOC has created evaluation protocols for children from birth to 5 and for school-age children. I highly recommend you pull these up in addition to the AHA guidelines. This will give you a lot of granular information on what you should be evaluating for and testing from birth through college. Remember, we talked before about measuring quality of life and how should we measure it. The primary cardiologist really focuses on physical morbidity. How are you feeling? How are you breathing? Having chest pain? How's your exercise tolerance? Do you have any heart failure, abnormal heart rhythms? Pediatric cardiologists really are not suited for, nor do they like to treat families for neurodevelopmental and psychosocial morbidity. So over the last decade and a half now, cardiac neurodevelopmental programs have now been created across the country to address this critical gap. So this is my program at Northwestern. When I was at Lurie, I built the 3rd program in the country, was at Cincinnati. We're opening our program here at Cleveland Clinic this summer. They're all very similar. They monitor and intervene on development. They offer high-risk NICU cardiac patients assessment, regular developmental evaluations from infancy to adolescence, psychology, neuropsychology evaluation and management, physical, occupational, and speech therapy, dietitians, social workers, nurses, and APNs, and then care from developmental pediatrician and special educator standpoint. The special educators are key because they, at least in Chicago, and what we'll do here, and what we did in Cincinnati, they will go for free with the family to the schools to advocate for the parents and for the child to make sure the school is giving the child what legally they have the right to have, that they can appropriately thrive in school and reach their maximal educational attainment. Care model is very simple. Pediatric cardiologists and adult congenital providers work with general pediatricians, family practitioners, and internists, and the cardiac and developmental program supports the neurodevelopmental psychosocial needs of the patients as they traverse this lifelong arc from pediatric care transitioning to adult care. So within the medical home, you can have several models, right? One is having a separate high-risk NICU and cardiac population, separate clinics with no interaction. In Chicago, we thought that was not the right thing to do. You could bring together the NICU and cardiac populations, but have separate non-MD core staff for efficiency. You could have, like we had in Chicago, a single developmental follow-up program for high-risk NICU and cardiac populations, so that it's fully efficient and you're seeing both the high-risk NICU and cardiac population. Or you can have a singular developmental follow-up program for all high-risk children that includes many populations. So when I was in Cincinnati, because the NICU team did not want to work with the cardiac team, we had 2 completely separate clinics with no interaction. When I was in Chicago, we had a single developmental support program for both NICU and cardiac patients. Now here at Cleveland Clinic, we're creating a singular developmental support program that looks something like this. So if you imagine that there are neurology, neurosurgery patients, cardiac patients, NICU patients, PICU patients, then you follow up, and I can blame you another 10 groups of patients. You would want to have a core team of a developmental pediatrician, a psychiatrist, psychologist, advanced practice nurse, habilitative services, nutrition, and social work to care for those patients across these multiple pediatric conditions. And then have specialists parachute in on given days when those patients are being seen. So we're starting cardiology this summer. We're starting NICU in 6 months. We're going to be doing PICU from a cardiac critical care medicine standpoint in a year. And we'll be adding in some of these other programs. And then you have to have additional consults in adolescent care, palliative care, genetics, and education. as needed for the appropriate age child who may be at the appropriate stage of transition, for example. So who's in the neurodevelopmental program? A developmental intensivist, someone like me, who's a cardiac intensivist or a NICU doc, who is interested in neurodevelopmental follow-up and wants to work with parents to see those children and understand and explain to families why the children have specific neurodevelopmental issues based on their specific disease. You have to have a developmental pediatrician, physical therapist, occupational therapist, and educators we discussed, and access to a psychologist, neuropsychologist, geneticist, neurologist, dietitian, and speech language pathologist. So the educator, to me, is the key piece to this, because you can have the greatest evaluation done by the greatest programs in the country, but if there's not someone to help those families take that important, critical, clinical, educational information and take that to the schools, it doesn't matter. So learning challenges are common in our CHD patients. 1/3 to 1/2 will receive special ed programming. 1 in 6 will be placed in a substantially separate classroom. 1 in 5 will repeat a grade level at least once. 1 in 4 will receive occupational therapy, physical therapy, speech therapy, and/or psychotherapy. The educator will see the patient in our clinic, and then they will follow up in the community schools to make sure the child's getting what they need. I like to say that, if you do an evaluation, but there's no communication to the school, it's like the tree fell in the forest and there's no one there to see it. So when I was a fellow back in the 90s, before we created all this neurodevelopmental programming across the country, I walked into rooms of kids in the ICU and I told them, we will save your child, they will be fine. I told a big lie. I didn't know at the time that I was lying, but half the children who have cardiac surgery that survive will have some neurodevelopmental psychosocial issues. The other issue in the last decade or so, 20 years, has been the grand re-education. We had to educate pediatric cardiologists, pediatricians, developmental pediatricians, psychologists, neuropsychologists, that kids with heart disease, just because their hearts are fixed, does not mean that they don't have neurodevelopmental psychosocial issues that need our attention and our efforts. So when we think about cardiovascular care and neurodevelopmental care and psychosocial support, it's really across the lifespan. I meet with families at a fetal care center to talk to them about what might happen during the perioperative period and then a longer term in the first 2 decades of life. They see me and I take care of them in the cardiac ICU. They then follow up in our developmental support program, and then they go to a bridge program, and then they get to the adult care. So comprehensive cardiovascular care includes comprehensive neurodevelopmental and psychosocial follow-up. The AHA has spoken about this in terms of this best practices for managing transition to adulthood for adolescents with congenital heart disease, led by Craig Sable. This is, if you have not gone there, you need to go to Got Transition. It's a terrific site and group that helps teach us about how to transition patients well with any pediatric chronic disease. This is from the American Academy of Pediatrics, their transition document. Here you can see it. The 6 core elements of transition include discussion of transition at 12 to 16, tracking progress, I should say, 16 to 26, assessing skills between 16 to 21, developing a transition plan 16 to 21, transferring between 21 and 26, and then completing transition by age 26. So in summary, CHD is the most common birth defect. Survival after neonatal heart surgery is now expected, with only 3% of the patients nationally dying after heart surgery. Neurobehavioral dysfunction CHD surgical survivors result from white matter injury. We need to maximize long-term health and quality of life through adhering to the AHA-AAP CNOC evaluation management guidelines. We need to monitor and intervene on development through cardiac neurodevelopmental programs. We need to appropriately transition teens with CHD to ACHD medical care and mental health support programs. I want to thank you for your time. It's been a pleasure chatting with you and happy to answer any questions.
Thank you so much, Dr. Marino, for your presentation. We are actually going to hold questions until after Dr. Miranda's presentation. And so Carlos Miranda is going to present the case study. He is a pediatric cardiologist who has worked with Sanford Health in Fargo